Hello, in this session we shall discuss the anatomy of the facial nerve and look at relevant clinical issues. These sessions would be conducted in two parts. In the first part we shall look at the intracranial and extracranial course of the facial nerve and focus on its motor function. In the second part we shall focus on the parasympathetic and gustatory functions of the facial nerve. In this presentation, we shall look at the anatomy of the main motor root of the facial nerve, its origin, intracranial and extracranial course, relationship of the facial nerve to the parotid gland and the clinical significance, innervation of the muscles of facial expression, including testing of the facial nerve, and finally, clinical recognition of upper and lower motor neuron lesions of the facial nerve. Facial nerve is the seventh cranial nerve and provides motor innervation to the muscles of facial expression. Some suprahyoid muscles such as the posterior belly of the digastric and the stylohyoid, and also a muscle related to the ear, which is the stapedius. The facial nerve also provides gustatory innervation to the anterior two-thirds of the tongue and parasympathetic innervation to lacrimal and salivary glands. Inside the brain, the fibers of the facial nerve arise from four nuclei which are located in the brainstem in the lower pons. When we say nucleus of a facial nerve, it means the cell bodies of the nerve fibers inside the gray matter of the brain. There are four nuclei related to the facial nerve. First is the motor nucleus, which is brachiomotor, the superior salivatory nucleus, and the lacrimatory nucleus. Both of these are parasympathetic, and nucleus of tractus solitarius concerned with taste sensation. So this is the gustatory nucleus. So this section depicts the nuclei of the cranial nerves, and we can look closely at the nuclei related to the facial nerve. So the motor nucleus of the facial nerve in the lower pons, the lacrimatory nucleus, the superior salivatory nucleus, the inferior salivatory nucleus is related to the glossopharyngeal nerve, and then we have the nucleus tractus solitarius, which is concerned with taste sensation related to the facial nerve. Inside the brain, the facial nerve arises as two separate roots in the pons, a larger motor root and a smaller sensory root, which is known as nervus intermedius. These two roots travel through the internal acoustic meatus, which is a 1 centimeter long opening in the petrous part of the temporal bone, also known as the internal auditory meatus, and is in close proximity to the internal ear. Still inside the temporal bone, the two roots of the facial nerve enter into a canal known as the facial canal, which is a Z-shaped structure within the temporal bone, and three events happen here. Firstly, the two roots, which is the motor and the sensory root or nervus intermedius, they fuse. The nerve then forms a swelling known as the geniculate ganglion, and then three branches of the facial nerve are given off from the fused nerve within the facial canal. The greater petrosal nerve, which carries parasympathetic fibers to the mucous glands in the nasal cavity, the palate, pharynx, and the orbital cavity, and also parasympathetic fibers to the lacrimal gland. So this is the first nerve which is given. This will form the preganglionic route to the pterygopalatine ganglion. Nerve to stapedius, which provides motor innervation to the stapedius muscle of the middle ear. And thirdly, the coda tympani branch, which is both special sensory carrying gustatory innervation to the anterior two-thirds of the tongue, and also parasympathetic secretomotor fibers to the submandibular and sublingual salivary glands via the submandibular ganglion. After giving off these three branches, the facial nerve exits the facial canal and the cranial cavity via a foramen known as the stylomastoid foramen, which is located posterior to the styloid process of the temporal bone. So here you can see a diagrammatic depiction that the motor root and the sensory root originate as separate roots, and when the nerve is traveling in the facial canal, it gives rise to a swelling known as the geniculate ganglion, and three branches are given off from the facial nerve within the facial canal: the greater petrosal nerve, the nerve to stapedius, and the coda tympani branch, after which the facial nerve exits the cranial cavity through the stylomastoid foramen. So this is another way to look at the course of the facial nerve. Originating inside the pons, the facial nerve enters the internal auditory canal and then traverses a Z-shaped canal in the temporal bone known as the facial canal, where it produces a swelling known as the geniculate ganglion, and then it exits the cranial cavity through the stylomastoid foramen. And during this journey through the facial canal, it is going to give off three branches: the coda tympani, the greater petrosal, and the nerve to stapedius. After exit from the stylomastoid foramen, the facial nerve pursues its extracranial course, and three branches are given off immediately after exit from the stylomastoid foramen. These include the posterior auricular nerve, which innervates the intrinsic and extrinsic muscles of the outer ear, and the occipital belly of the occipitofrontalis muscle, which is a muscle related to the scalp. We shall look at the frontal belly a bit later, which is innervated by another branch of the facial nerve. The nerve to the posterior belly of the digastric muscle, and as you know, digastric is one of the suprahyoid muscles which is responsible for the elevation of the hyoid bone and also depression of the mandible. The interior belly of the digastric muscle, you might remember, is innervated by the nerve to mylohyoid, which is a branch given off from the inferior alveolar nerve before it enters the mandibular foramen, and the nerve to mylohyoid supplies not only the mylohyoid muscle but the anterior belly of the digastric muscle. And finally, the third branch after exit from the stylomastoid foramen is the nerve to the stylohyoid muscle, which is another suprahyoid muscle responsible for elevating the hyoid bone. After exit from the stylomastoid foramen and giving off three branches mentioned in the previous slide, the facial nerve enters the substance of the parotid gland, which is positioned along the posterior border of the mandibular ramus, and gives off its five terminal branches, including the temporal branch, which innervates the frontal belly of the occipitofrontalis muscle, the orbicularis oculi muscle, which is present around the eye socket and is responsible for pursing the eyelids, and the corrugator supercilii. The zygomatic branch innervates the orbicularis oculi and some other muscles such as the zygomaticus muscles. The buccal branch innervates the orbicularis oris, which is a muscle around the stomodium or the mouth cavity, the buccinator, and the zygomaticus muscles. The marginal mandibular branch, which innervates the muscles related to the lower lip, including the depressor labii inferioris, depressor angulioris, and the mentalis muscle. And finally, the cervical branch, which innervates the platysma muscle in the neck. So this image depicts the terminal branches of the facial nerve. So after exit from the stylomastoid foramen, the facial nerve is going to enter the parotid gland and give off its 5 terminal branches, which innervate the muscles of facial expression: the temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical branch. So this image depicts the origin and course of the facial nerve, originating in the lower pons from 4 separate nuclei. The motor route accompanies the sensory route into the internal auditory canal, where the motor and the sensory routes, they join together and form what we call the geniculate ganglion, and 3 branches of the facial nerve are given off in the facial canal within the petrous temporal bone: the greater petrosal nerve, which provides parasympathetic innervation to lacrimal glands and also salivary glands; the coda tympani nerve, which provides gustatory innervation to the anterior 2/3 of the tongue and parasympathetic innervation to the submandibular and sublingual salivary glands; and the nerve to stapedius. And from the facial canal, the facial nerve exits the skull through the stylomastoid foramen, where it gives off 3 motor branches: the posterior auricular, the nerve to the stylohyoid muscle, and the nerve to the posterior belly of the digastric. And then finally, the nerve traverses the substance of the parotid gland to give off its 5 terminal branches: the temporal, the zygomatic, the buccal, the marginal mandibular, and the cervical branch of the facial nerve. Now we shall briefly review different groups of muscles of facial expression and how their actions can be used to test the facial nerve. The frontalis muscle is innervated by the temporal branch of the facial nerve, and to test its function, you ask the patient to look upwards without moving the head, and you could look for symmetrical horizontal furrows on the forehead, indicating normal function of the normal contraction of the frontalis muscle, which in turn indicates normal function of the facial nerve. If facial nerve is damaged on one side, you would see a difference in the depth and degree of furrows which are produced on the forehead. Next, you can look at the functions of the corrugator supercilii and the procerus muscles. Frowning and producing vertical wrinkles on the forehead indicates normal function of these muscles. Next, we can look at the orbicularis oculi muscle action. Tight closure of the eyes indicates normal function of this muscle, and you shall see in the later part of this presentation, when there is unilateral facial paralysis, the patient is unable to close the eye on the affected side, indicating that the function of the orbicularis oculi muscle is compromised due to damage to the or impaired function of the facial nerve. Next, we can look at the function of the orbicularis oris muscle. The ability to whistle and purse the lips together, as in pouting, which you see all the time on the social media nowadays, that indicates normal function of the orbicularis oris muscle and shows that the facial nerve is intact. Next, we can look at the contraction of the dilators of the mouth, which include levator labii superioris and depressor labii inferioris. Contraction of these muscles together allows an individual to grin to show the teeth, indicating normal function of the facial nerve. The ability to puff the mouth and blowing out the cheeks, particularly against resistance, is a function of the buccinator muscle, which is attached to the uh, posterior aspect of the alveolar arches in the molar regions, both in the maxilla and the mandible, and this muscle is responsible for preventing the accumulation of food in the buccal vestibule. So ask the patient to blow out the cheek against resistance, and if they are able to do that, that indicates normal function of the buccinator muscle and shows that the facial nerve is intact. You can also look at the function of the platysma muscle, which is a large muscle in the neck, a superficial muscle, and forcibly pulling the angles of the mouth downwards and backwards will form prominent vertical folds in the neck, uh, and that is a function of the platysma muscle along with the risorius muscle, and indicates the ability to do that indicates normal function of the platysma muscle and the fact that the facial nerve is intact. And towards the end, we can also look at some of the other recognized facial expressions, such as demonstrating happiness, laughing, and this is a function of the zygomaticus major muscles when they contract, along with the levator labii superioris, which pulls the upper lip upwards, and the depressor labii inferioris, which pulls the lower lip downwards, showing the teeth as in laughing or smiling. Finally, uh, the expression of sadness on the face is a function of the depressor anguli oris, which pulls the angles of the mouth and the lower lip downwards, demonstrating sadness and grief. The expression of anger involves contraction of the dilator nares, which is part of the nasalis muscle surrounding the alley of the nose, and the depressor septi, which is located beneath the uh, tip of the nose. The most important clinical consideration with facial nerve function is facial paralysis, and this could be related to a wide variety of conditions, including intracranial pathologies, extracranial pathologies, iatrogenic damage, systemic conditions, etc. So we shall look at some of the common conditions, and we shall then towards the end discuss differences between the presentation of facial paralysis with uh, nuclear and infranuclear lesions in the brain. So one of the common causes of facial nerve paralysis is cerebrovascular accidents or strokes, which could either indicate cerebral hemorrhage or cerebral ischemia due to emboli or thrombi or transient ischemic attacks. Then any mass lesion in the brain like a tumor or a cyst can lead to facial paralysis. And then there are a variety of conditions like multiple sclerosis, Mobius syndrome, Guillain-Barré syndrome, etc. Neuropathy in diabetes, and central and uh, systemic infections can also involve the facial nerve. Central lesions are termed supranuclear if the site of damage in the brain is above the location of the facial nerve nuclei, the motor nucleus of the facial nerve, and the causes of supranuclear lesions involve stroke, neoplasms, degenerative central nervous system disease, and supranuclear lesions manifest as contralateral paralysis of the lower face. The upper face is spared, so the muscle function in the upper part of the face is intact. It's only the contralateral lower face which is affected, and there could be associated hemiparesis. And we shall discuss why the paralysis occurs on the contralateral side and only involves the lower part of the face with supranuclear lesions in the later part of the presentation. Damage involving the brain tissue related to the facial nerve nuclei or parts of the brain below the facial nerve nuclei. The lesions are termed nuclear or infranuclear respectively. The damage could occur in the pons due to infarction or hemorrhage, demyelination, or at the cerebellopontine angle due to neoplastic lesions, and it presents as ipsilateral weakness of all parts of the face. So the face on the side of the damage, the entire face will demonstrate weakness of the facial nerve. A wide variety of systemic infections can also involve the nerves, and one of the most recognized is varicella zoster or herpes zoster virus, which can lead to Ramsay-Hunt syndrome, which is characterized by facial paralysis, and then a variety of other infectious diseases can also lead to facial nerve paralysis. As we know that the terminal part of the facial nerve is located within the substance of the parotid gland, so therefore any trauma, parotid malignancy, parotid surgery can lead to permanent damage of the facial nerve on the affected side. Similarly, transient facial nerve paralysis could result from deposition of the local anesthetic solution in the vicinity of the parotid gland, and this usually is related to inferior alveolar nerve blocks. If the needle is inserted too far into the tissues, the needle may get very close to the parotid gland, and deposition of anesthetic solution could result in transient facial paralysis. So this image depicts the exposed parotid gland during a surgical procedure, and you can clearly see how closely the branches of the facial nerve are related to the parotid gland. They are basically embedded within the substance of the parotid gland. So therefore, surgical procedures such as parotidectomies entail the risk of damage to the facial nerve. Similarly, malignant tumors involving the parotid gland can lead to involvement of the facial nerve. So this image depicts the relationship of the parotid gland to the mandible. So R is the ramus of the mandible, P is the parotid gland, MP is the medial pterygoid muscle, and this space between the medial pterygoid muscle and the mandibular ramus is the pterygomandibular space. That's where you insert your injection needle when giving inferior alveolar nerve blocks, and you can clearly see that the path of insertion is such that if the needle is advanced too much, anywhere above 3 centimeter into the pterygomandibular space, it can be very close to the parotid gland and can anesthetize the branches of the facial nerve, which will translate clinically into paralysis of the facial nerve on the ipsilateral side. These images show facial paralysis following an inferior alveolar nerve block in a young male. You can clearly see that the angle of the mouth is pulled to one side, uh, and the best way to tell which side of the face is paralyzed is to ask the patient to try and shut their eyes. Inability to close the eye indicates the side on which the facial nerve is paralyzed, and also you can see the angle of the mouth is pulled to the other side where there is normal function of the facial nerve. This side is paralyzed, but it's important. As a beginner you might get a sense, because this looks abnormal, you might think this side is paralyzed. This is the normal side. The only reason why the angle of the mouth is pulled to that side is because the nerve function is normal on this side, and it is this side which is with the left side of the patient which is affected, which can be confirmed further by asking the patient to shut their eyes tightly to check the function of the orbicularis oculi muscle. Then you can also ask them to produce horizontal furrows on the forehead by looking upwards without moving their head to see the contraction of the frontalis muscle. And then you can also check the function of the orbicularis oculi muscle, the orbicularis oris muscle, and a range of other muscles we discussed previously. Other causes of facial nerve paralysis include middle ear disease, Bell's palsy, which we shall discuss in a moment, and trauma to the head or the maxillofacial region, which can involve the facial nerve. So Bell's palsy is one of the most recognized forms of facial nerve paralysis. It's an acute unilateral paralysis associated with neuritis involving the facial nerve within the facial canal. It is regarded as an idiopathic condition, but sometimes may follow abnormal immune response to reactivated herpes simplex virus, which resides in the geniculate ganglion following the initial infection. And triggering factors could be exposure to cold, trauma, or infections which may contribute to nerve ischemia. And familial occurrences are also reported. So one of the most recognized forms of facial nerve paralysis is Bell's palsy, as we said. So next we can look at some of the signs of Bell's palsy. These include facial asymmetry. You can see the corner of the mouth being pulled to one side, which is the left side on this occasion, which means the right side of the face is paralyzed. Drooping of the eyebrows, you can see on the affected side, the eyebrow is drooping compared to the normal side. Loss of forehead wrinkles and nasolabial folds. So you can clearly see a prominent nasolabial fold on the normal side and loss of nasolabial fold on the affected side. Drooping of the corner of the mouth. Inability to close the eye, which obviously isn't visible on this image. Difficulty in pursing the lips together due to compromised function of the orbicularis oris muscle. Drooling of saliva. Collection of food in the buccal vestibule on the affected side, which would be due to compromised function of the buccinator muscle. Hyperacusis, which is loud noise intensification due to compromised function of the stapedius muscle. And if the facial paralysis were to remain unresolved and untreated, persistent facial paralysis would lead to muscle atrophy. So the muscles of facial expression on the affected side would atrophy over a period of months and years. A fundamental concept when understanding the presentation of facial nerve paralysis are the differences in upper motor neuron lesions and lower motor neuron lesions. The upper motor neuron lesions involve damage to the motor cortex of the brain above the level of the facial nerve nucleus in the pons. Hence, these are termed supranuclear lesions, whereas the lower motor neuron lesions involve damage to the facial nerve uh, from the facial nucleus to anywhere along the peripheral branches of the facial nerve. Hence, these are termed infranuclear lesions. Bell's palsy is a typical example of lower motor neuron lesions because the site of damage is the facial canal, which is well below the facial nerve nucleus. On the other hand, if a cerebrovascular accident or stroke involves the motor cortex, it is going to present as an upper motor neuron lesion because the site of damage is above the superior to the nucleus of the facial nerve in the pons. Now the thing to understand is that the upper part of the face involves dual innervation, so it receives innervation from both sides. So therefore, if there is an upper motor neuron lesion, the upper part of the face is spared and the paralysis would only be seen in the lower part of the face. And the other thing is that the facial nerve fibers, they cross over at the level of the pyramid. So therefore, damage to the brain on the left side would manifest as uh, with a supranuclear lesion, it would manifest as contralateral paralysis of the lower face. Whereas with infranuclear lesions, both the upper and lower muscles of facial expression would be affected and the damage would be seen on the ipsilateral side, that is the same side on which the facial nerve is damaged. So in Bell's palsy, as we said, the damage, if it occurs on the uh, involves the right facial nerve, it would manifest as full face paralysis on the right side of the face. Similarly, if you accidentally inject local anesthetic into the parotid gland during a right inferior alveolar nerve block, the entire right side of the face could be paralyzed and would manifest with typical features such as incomplete closure of the eyes, hyperacusis, loss of taste sensation to the anterior two-thirds of the tongue, collection of food in the buccal vestibule, etc. on the same side. So it's important that you are able to differentiate between supranuclear lesions, which present as facial paralysis of the lower part of the face on the contralateral side, and lower motor neuron lesions which present as full face paralysis on the ipsilateral side. So some of the texts which are recommended for further reading are the Netter's Head and Neck Anatomy for Dentistry. This will give you the essential knowledge for the anatomy of the facial nerve, and Physiology for dental students, which will give you information about testing the facial nerve. Thank you.